Hello, my name is Sarp. I am the founder of the company Askletion. We are helping over 15 years from different countries, the patients who don't have enough chance to access the modern medical treatments methods with a high quality and with a good price. We want to send you from to Turkey big respects and greetings for your Congress, and we are here to inform you with Professor Akan from Turkey in order to inform you two new interventional radiological methods. One of them is irreversible electroporation treatment, which is used for the treatment for oncological diseases of liver and pancreas, and the other is ablation, radioablation for gepatocellülarnej carcinoma. I want to give a much more information, a bit detailed information about Professor Akan. He is graduate from Hacettepe University of Medical Sciences, Faculty of Medicine in 1987, and has been working as a professor since 1996. If you don't mind, Mr. Akan, we can start with ablation for gepatocellülarnej carcinoma. Mr. Akan, yes, please.
Thank you very much for the kind introduction. What I'm going to talk for will include image-guided tumor ablation for HCC. First of all, I am going to make an overview for the indications, results of the procedure, containing all series with consecutive patients, retrospective as well as prospective studies. Surgery is the traditional choice of treatment for the hepatocellular carcinoma. Unfortunately, it is not applicable in most of the patients. Only up to 20% of the patient can be treated by surgery because of several reasons, such as extrahepatic diseases, inadequate liver reserve after the surgery, multifocal diseases, difficult location of the lesions, and patients with comorbid diseases. Transplantation is the most important solution for the lesion of HCC. Patients with cirrhosis in the middle of Milan criteria, 5-year survival rate is more than 70%. 10-year survival rate is around 50%. However, recurrence is one of the major problems, seen up to 15% at 5 years. On the other hand, there are two major problems with transplantation. The first one is related with shortage of organ. The second one, prolonged waiting time for the list. Image-guided ablation is a kind of potentially curative treatment for early stage of HCC according to the guidelines. When I say guidelines, of course, BCLC is the most important one, widely accepted by the globe, and as you see at the very early stage ablation is the most important choice for the treatment. At the very early stage, which means that there is a single lesion smaller than 2 cm, is treated by ablation if the patient is not a kind of candidate for transplantation. Otherwise, ablation is the solution. If they are 3 lesions up to 3 cm, or I can say smaller than 3 cm, if patient is a candidate for liver transplantation, resection theoretically could be an alternative, but before transplantation, if they are more than 1 lesion, surgery is not preferred. Ablation is the solution in this kind of patients. We have several techniques. Percutaneous approach is widely used for the treatment of HCC or any kind of focal liver lesion. As seen on this slide, on the right-hand side, there is a small lesion next to the diaphragm. Under CT guidance, it was treated by RFA. CT or ultrasonographic guidance can be used. It is also possible to carry out the procedure intraoperatively under ultrasonographic guidance as well as laparoscopically. The goal of ablation includes to ablate not only the lesion itself, but also the normal tissue around the lesion in order to create a kind of safety margin after ablation. Radiofrequency ablation was the most commonly used thermal ablation technique in the past, especially between 1997 and 2010. But in last 10 years' time, microwave ablation has already mostly replaced RFA, and it has become a part of our daily life. This is one example. Cirrhotic liver under ultrasonography, there is a lesion, HCC lesion, and treated by RFA. Another one, lesion located in segment 4, treated by RFA, and 9 months later, there was a recurrence, treated by second intervention, and 2 years later, there was no any other recurrence or new lesion. However, microwave ablation has several advantages over RFA. That is why we prefer to use it in last 10 years. It creates larger ablation zone. It's possible to have more quick ablation. Heat sink effect is seen very lower with lower rate than RFA creates. It is associated with lower pain without need of any pads. The most important points also include some results for small lesions. The result of RFA and microwave has identical results. However, if the lesion size is larger than 3 cm, most probably microwave is more effective than RFA. I'm going to show several cases. A patient, 75-year-old with cirrhosis and HCC lesion, as seen in segment 6 and effectively ablated. Another one appeared several years later, just under diaphragm, also treated by second ablation without damaging on diaphragm and lung tissue. 56-year-old female had a lesion located in segment 3, effectively ablated, and during the follow-up it gets smaller with granulosus necrosis. A lesion located in segment 1, which means that between portal vein and IVC, which is very difficult location, under CT guidance, effectively ablated. In the follow-up, there was no recurrence, besides a new lesion, which was ablated on the other section. 71-year-old male patient, after left lobectomy, there were 2 new lesions located in segment 8 between vessels and segment 6. Ablation carried out by using microwave, and 3 months later we should have already understood that ablation was effective. Another one, close to capsule, ablation successfully performed, and 1 lesion close to the heart, ablated effectively, and 1 lesion between portal vein, IVC, and hepatic vein. Under ultrasonographic guidance, microwave probe is placed correctly, and ablation was started immediately in order to cover all the dimension of the lesion. Another case, 76-year-old male with cirrhosis. That is why the patient had transplantation. Unfortunately, recurrent 2 lesion, 3 lesion were diagnosed, treated by microwave. As a complication, an abscess developed after a month, treated by percutaneous drainage of abscess. And 2 years later, patient came back with 2 new lesions. One was located between 2 vessels. That is why I have chosen IRE for the treatment in order to preserve the flow of the vessels.
Sorry for interrupting, Professor. It's a patient for after transplantation operation.
Yes.
No, thank you very
Yes.
much.
That is why, in order to reduce the risk of infection, I prefer IRE for this kind of patient, as infection rate is lower than microwave ablation.
Thank you.
That was the reason. And you can see a prop of IRE in the liver. Procedure was carried out successfully, and during the follow-up, before the procedure, there was lesion, hyperechogenic lesion after contrast enhancement between the vessels treated by IRE, and during the follow-up, as you see, preservation of the vascular structure is very permanent feature, and there is no clue for the lesion treated by IRE. That was the great result for this patient. What was the advantages of the IRE in this kind of patients? By using this, we can preserve vessels, bile ducts, probably nerves, without any heat sink effect. Radiofrequency ablation in patients with Milan criteria is really very effective alternative for the treatment, as RFA is associated with shorter hospital stay and lower complication rate. Also, 5-year overall survival with RFA is almost 33% of the patients, besides hepatic resection close to the 50%. In the literature, there are several randomized controlled trials, and in one of them, 3-year survival is almost identical. 4-year survival in another prospective randomized trial published in 2006 also results statistically. There is no statistically significant difference between two alternatives. I mean, radiofrequency ablation and hepatic resection. What is the role of microwave? I can briefly summarize that total ablation rate is almost 100% in one of the important paper. If the size of the lesion is smaller than 3 cm and local tumor progression, I mean recurrence rate, is under 10%, which is really very effective. Which one is better? The answer of this question on the basis of literature, microwave is better for larger tumor, larger than 2 cm, up to 5. If the lesion size is smaller than 2 cm, there is no any statistically significant difference between radiofrequency ablation and microwave ablation. I can conclude that microwave is better than RFA for the larger lesion. What is the take-home messages of this short presentation? If liver transplantation is an option and patient fulfill the criteria for surgery, hepatic resection can be chosen if the lesion number is single and smaller than 2 cm. Otherwise, ablation is the option, and microwave or RFA has similar results. If ablation is not feasible for any reason, and then hepatic resection can be a kind of option for single HCC smaller than 2 cm. Theoretically, of course, stage migration, on the basis of stage migration, TACE could be an alternative as well. Maybe in another presentation, I will have a chance to talk on the results of TACE and transarterial radioembolization. Microwave ablation is the best option for HCC smaller than 3 cm at the early stage, which means up to 3 lesions smaller than 3 cm. Hepatic resection is the best option for larger tumors if the lesion is single. Larger tumors means more than 3 cm lesions located in any part of the liver can be easily resected on the basis of surgical routes. For the early stage, liver transplantation is a better choice. Hepatic resection and ablation are hampered by a high risk of recurrence if liver transplantation is an important option for the patient. Otherwise, of course, ablation is the most important alternative for the treatment of the patients. Of course, life is going on. We still need further studies and evaluation. Since 1999, BCLC have already been updated several times on the basis of the last version published in 2022. I have already tried to summarize all the features in the literature. Thank you for your attention.
Thank you for first speech, Professor Akhan. Now it's turn for the second method, which is used for the treatment of diseases of oncological diseases of liver and pancreas, which is irreversible electroporation. It's your turn, please.
Thank you very much, Sarp. I would like to present treatment alternative for pancreatic cancer by using IRE. This is a new innovative technique widely used for pancreatic cancers, as well as some liver lesions and some prostate cancer. What is the physical mechanisms behind the technique? IRE induces cell death by creating permanent nanopores in the cellular membrane using high voltage direct current. These nanopores disrupt the cellular hemostasis, allowing transportation of molecules, resulting in cell death via apoptosis. But on the other hand, collagenous structures are not affected. This is the most important characterization of this technique. It means that because of the collagenous structures such as vessels, nerves, or biliary ducts, this technique theoretically does not harm this kind of structure. It's an example. I have already shown this one the previous presentation, a lesion between vessels treated by IRE, and during the follow-up on MRI, you can easily see disappearance of the lesion between vessels which are still open, and flow of the blood is preserved. What is the indication? Stage 3 pancreatic adenocarcinoma, which means they are invasion of the cancer to the vessels, resulting in unresectable lesion. In this group of patients, surgery is not possible, and then IRE can easily be applied percutaneously or intraoperatively. If the lesion is smaller than 3.5 cm, after the patient receive chemotherapy, induction chemotherapy for at least 3 cycles. One of the early study published in 2012, retrospective comparative study, to compare the results of IRE and classical pancreatic cancer therapy, which means chemotherapy plus radiotherapy. And there was statistically significant difference in terms of overall survival, which was 20 months with IRE versus 13 months with conventional treatment. 2 years later, the same group presented the newest series in which overall survival was 23 months. And finally, in 2015, the largest series in the literature was published, containing of 200 locally advanced pancreatic adenocarcinoma treated with IRE, and in this group of patients, median follow-up was 29 months, local recurrence was 3%, which is very low, and median overall survival was almost 25 months. Another paper published from University of Miami in 2017, and if the lesion smaller than 3 cm, as it was seen very well, overall survival was more than 33 months. And a retrospective comparative study included 32 patients for each group, which were IRE and radiotherapy, and the results clearly showed that, for example, 2-year overall survival, the results of IRE were better, statistically significant, better results than radiotherapy. I would like to show some examples. 34-year-old female patient with inoperable pancreatic carcinoma. Before the procedure, portal vein was invaded, and after the procedure, as you see, there is no contrast enhancement after IV contrast administration. 1 week later, there was a kind of ascites secondary to the leakage of bile duct related to the procedure, and then after percutaneous biliary drainage, we just treat the leakage by using covered metal stent. During the follow-up, there was no recurrence, local recurrence at the level of pancreatic head. Unfortunately, 6 months later, patient died because of SOS, which means sinusoidal obstruction syndrome secondary to chemotherapy. Another patient treated by IRE first and resected by surgeon by using Whipple operation. 1 year later, there was no recurrence. Another one, lesion invaded SMA and SMV, treated by intraoperative IRE. As you see, between the metal stent, the distance between metal stent and vessels is statistically reduced, significantly reduced, which means that the tissue between stent and vessels, non-functional granulation tissue. Another one, small lesion treated by IRE. On the follow-up, there was no recurrence. After 6 months on MRI, it was clearly necrotic. I can conclude that IRE is a safe and effective procedure in patients with locally advanced stage 3 pancreas adenocarcinoma. In the largest series, mean overall survival rate climbs up to 27 months. On the other hand, IRE can boost the immune system. For example, local immune response could result in the destruction of micrometastases in lymph node. I think this innovative technique should be used in most of the patients with stage 3 pancreatic adenocarcinoma, besides liver and prostate lesions. Thank you very much for your attention.
Professor Akan, I will have a question for our patients.
Yeah, sure.
How long the patient need to stay in hospital after this procedure?
If the procedure is carried out under CT guidance percutaneously, which means that it should be smaller than 2 cm, the next day, most probably, I can discharge the patient. But if lesion is smaller than 2 cm, which means that patient will be needed intraoperative treatment, and then approximately 5 to 7 days is just enough to be in charge of the hospital.
And in the future, if there is a need for the repeating procedure, it's possible to repeat the same procedure after some time?
Yeah, if local recurrence develops during the follow-up, of course it is possible to carry out the procedure on the second session.
Thank you for your participation, for your support, for your cooperation, and for a nice speech, informative speech. I hope we will soon again meet and for new informative speech. Thank you very much.